Hello everyone. This is going to be a brief orientation for the first year exam for the year 2025. And of course, as you know, the exam is going to include the end of module exam. All the exams will be on the same day, the end of module exam, which will be composed totally of MCQ multiple choice questions where one answer is to be chosen, and then the end of year exam, which is mainly going to be short answer questions to be answered in writing on the same sheet that you will be supplied on the same booklet, and also will be included your brief practical exam. So what I'm going to explain now is basically your what we call the blueprint, and this is going to be of great help for you when you study, as I'm going to explain right now. As you can see, you are provided with the ILOs. And what are the ILOs? These are the intended learning objectives, or the outcomes that we want to get from your studying. I know you're provided with text. Sometimes you don't know what to do with this text. Are you going to memorize it? Are you going to understand it? How are the questions going to be included or covering each part of this text? This is what I'm going to explain. So basically speaking, you have three forms of questions, which are the short answer questions, as you can see, the MCQ questions, and the part which is the practical part, which we call the objective structured practical exam, or the OSPE. So what you get here are the intended learning objectives, what we want you to know from studying medical pharmacology, and how we are going to test you regarding this particular objective. So by using this table, you will know which parts you are going to memorize for short answer questions. For the rest of the curriculum, you need to answer, you can be asked a multiple choice question in any part of your curriculum, of course. And then there will be a brief description at the end regarding the practical part of the exam. So I'm going to go through the ILOs one by one. So first ILO is to explain the difference between pharmacokinetics and pharmacodynamics. And I know this comes in the very beginning of your curriculum and it seems very obvious. But in fact, we need you to have very deep understanding about the difference between kinetics and dynamics. For example, you might get an MCQ question describing a certain process and asking you whether this is a kinetic or a dynamic process. So you should be able to differentiate whether this interaction or whether this phenomenon or whether this description is about the relation, what the drug does to the body or what the body does to the drug. And why is this? Because we want to highlight the great importance of pharmacokinetics. I know you always focus about the drug's mechanism of action. You will see that when you go to your second year and third year. You'll be very much concerned with the drug's mechanism of action and its actions, but the kinetics are also very important. That's why we need a deep understanding in this part. To explain the meaning of pharmacotherapeutics, this is simply just like the definition says. This is not really deep. It's going to be something quite superficial. To understand the importance of maintaining a therapeutic drug plasma concentration to achieve a therapeutic target. Here, we want to highlight the importance of the plasma concentration. Without having an adequate, well-maintained plasma concentration of the drug in the blood, you will not get a pharmacological action. So all the actions that you describe about drugs, all the talk about an agonism, antagonism, dose-response relationship, concentration-response relationship, it will not happen unless the drug reaches and maintains adequate concentration in plasma. So this is just about appreciating this and understanding this. Then to describe the different ways of passage of drugs across membranes, you need to understand this part very well. With each method of drug passage, like the simple diffusion, like the facilitated carrier-mediated passage of drugs that don't really need an energy but need carriers, and the active transport. So you need to understand the differences between or among these methods. Then to explain the importance of the medium's pH and drugs pKa in determining the lipid solubility of drugs. By now, I'm sure you understand very well how lipid solubility of a drug is very important. Okay, for a drug to reach its site of action, to be able to pass through membranes or different barriers, it needs to be lipid soluble. So you cannot have an ionized drug and being lipid soluble. For a drug to be lipid soluble, it has to be non-ionized. That's why you need to understand what makes a drug ionized or non-ionized, which is the relation between the pKa of a drug. pKa of a drug is an intrinsic property of a drug. It is the pH at which the drug is half ionized and half non-ionized. Why is this? Why do we mention this point exactly? Because we need to choose a point. So we simply choose the 50% to describe the tendency of drug to be ionized or non-ionized in relation to the pH of the medium. Now, combination of this pKa with the actual pH of the medium, it determines how much ionized or non-ionized the drug is. So an acidic drug in an acidic medium is less ionized and is going to be lipid soluble. However, the acidic drug, if you put it in a basic medium, it's going to be ionized and it's going to be less lipid soluble. I know this much, you know. What about the Henderson-Hasselbalch equation? I don't expect you to memorize the equation, but the main message I want you to get here is, or what this equation wants to tell us, is that 1 point change in pH is going to change the degree of ionization 10 times, because it is a log relationship. So all I need you to know here is the great importance of the pH. Like if you're going to change the pH of the medium in the GIT, or if you're going to change the pH of breast milk, or if you're going to change the pH of urine by 1 point, this is going to affect the degree of ionization and solubility 10 times. That's why it's a very important piece of information and a very important thing to understand, because again, this has an implication on the amount of drug absorbed, on the amount of drug excreted, whether you need to keep this drug in the body or you need to get rid of this drug out of the body. Again, this is explaining about the pH of the medium and how it is important in drugs absorption and excretion. You need to know, you can be asked MCQ questions about the factors affecting absorption and oral absorption of drugs. And this again affects the bioavailability of a drug. If a drug is going to be well absorbed, it needs to be well absorbed to be bioavailable. So it might come as factors affecting absorption of drugs or factors affecting drug bioavailability. Again, as you can see, all these ILOs, they come in MCQs. So if you understand exactly what I'm saying word for word, you will be able to solve your MCQs very easily, very easily. So next, here come some ILOs that need memorization. Any definition that you have needs memorization. So basically speaking, if you find anything with a definition or any table that shows comparison, you need to memorize that. One important point, some ILOs tell you to compare. Okay, comparison is a higher level of understanding. So this means that the question might ask you to describe one of the two things that you are comparing. Okay, so I'm going to explain this more when the time comes. So define bioavailability, you need to memorize the actual definition. To describe the different patterns of drug distribution, this will come in MCQ questions. You need to know that some drugs, like those with very high molecular weight, are retained within the circulation. And so they are going to have small volume of distribution, and they are going to have one compartmental pattern of distribution. Drugs that are smaller in size, even if they are not very lipid soluble and they can diffuse out of the blood vessels, they can be distributed in the extracellular fluid. And drugs that are quite lipid soluble with small molecules, they can be distributed in the total body water. So these are the patterns of distribution. You need to understand about them very well, and understanding that helps you or permits you to solve MCQ questions. In the meantime, you should be able to know the implications of this on the volume of distribution of a drug. If a drug distributes intravascular, it's going to have very small volume of distribution. If a drug is distributed widely, or if it hides in a certain tissue, like a drug that hides in the bone and disappears from plasma, a drug which is very lipid soluble and hides in adipose tissue, this is going to have a very large volume of distribution. And again, why is that? Because to calculate the volume of distribution, we divide the dose of the drug by the plasma concentration that we measure in plasma. So if you give a big dose of a drug, but then this big dose, it hides away, it diffuses. The drug is very lipid soluble, is going to hide in adipose tissue. What is going to remain in plasma? A very small concentration. So when you divide the dose that you have given by this small concentration, are you going to get a small number or a big number? You are going to get a big number. So this drug is going to have a very big volume of distribution. You are going to get more explanation about this the next year, inshallah, but I am preparing you and telling you that this is a very important point that you should understand. You should memorize the factors that affect the distribution of a drug. This is something that can come in a short answer question. To understand the clinical implications of drug passage across the blood-brain barrier and the placental barrier and through breast milk. This is something simple. It doesn't really need deep understanding. You should be able to know that a drug that passes the blood-brain barrier, for example, might affect the CNS functions, that sometimes you need this passage across the blood-brain barrier when you are treating CNS infection, for example. That's why we depend on the fact that some antibiotics might not pass the blood-brain barrier under normal conditions, but if the meninges are inflamed and if there is CNS inflammation, now there is more blood supply, there is vasodilatation, there is more capillary permeability, in which case there will be more passage of these drugs across the blood-brain barrier. Again, passage through the placental barrier is very important because it has its implications on the fetus, especially in the first trimester, the first 3 months of pregnancy. If a drug passes through the placental barrier, it might adversely affect the fetus and result in what we call teratogenic effect or congenital malformations. Again, something which is very frequently forgotten is the effect of drugs on the suckling baby or the breastfed baby, because drugs might pass through the breast milk. Not just this, some drugs might be trapped in breast milk by the process of ion trapping as well. So you should also concentrate or understand this phenomenon, the phenomenon of ion trapping of drugs, and how a change in pH, like for example, if a basic drug enters acidic urine, in the acidic urine, this drug is going to be non-ionized. It will not be reabsorbed. It will be trapped in the urine. So same goes for the breast milk. So ion trapping is important in drug excretion and drug passage to the breast milk, and through the breast milk this is going to affect the suckling baby as well. To define the volume of distribution, you need to define this, and you need to know it by heart. This again might come as a short answer question. To explain the clinical importance of the volume of distribution, this might come as an MCQ question, and I already explained about that, how drugs that hide in certain tissues have very big volumes of distribution. Drugs with high molecular weight will be distributed inside the vascular compartment. This is important regarding the dose that you will give. To enumerate the sites of metabolism of drugs, we're interested here for you to know that metabolism is not solely inside the liver, that several organs can perform drug metabolism. So just know this as a fact. And when it tells you enumerate or mention, this is something that you need to know very superficially. It is just a simple fact that you need to know. Now, next, to compare the phases of drug metabolism. Again, if I say compare here, you should be able to compare phase 1 and phase 2 drug metabolism. Of course, needless to say that phase 1 and phase 2, they don't signify order. So not all drugs will undergo first phase 1, and not all drugs will undergo phase 2. So some drugs will undergo only phase 1. Some drugs will undergo phase 2. Some drugs will go through phase 1 and then phase 2. Some drugs will go through phase 2 and maybe after that will go into phase 1. Again, there is no particular rule. Through phase 1, drugs may be activated rather than inactivated, and some drugs may even be more toxic. These are phenomena that you need to understand very deeply and very well. You need to understand about, so when I tell you, you compare the phases of drug metabolism, for example, this means that you know all details about each phase. So you might be asked to describe one of them. So again, this is what I want you to understand. When the ILO tells you to compare, this is a higher level of study. This is a higher level of understanding. So the question can come as a comparison question, or the question can come simply asking you to describe one of the two things that you have been asked to compare. Factors that affect drug metabolism are very important, and the consequences of microsomal enzyme induction and inhibition. The fact that if you give a hepatic microsomal enzyme inhibitor and this enzyme is inactivating a drug, if you're going to inhibit this enzyme, you are going to inhibit the inactivation of this drug substrate, which means that the drug concentration is going to increase. You might get more effect or you might get toxicity. This is the simple case. The exact opposite is if you give a drug metabolized by hepatic microsomal enzymes and you give a hepatic microsomal enzyme inhibitor. Inducer. If you give an inducer, what does it mean, an inducer? An inducer increases the amount, the actual synthesis of the enzymes. So if you give me a drug which is metabolized by hepatic microsomal enzymes, and then you give me an inducer of the same enzyme, it is going to increase the inactivation of the drug. The drug, like for example, if you give me drug A and hepatic microsomal enzyme inducer drug B, I am going to get an increased metabolism of A. I am going to increase to get a decreased concentration of drug A and a decreased effect. Okay, so this is the basic relation, or this is the basic consequence or effect of hepatic microsomal enzyme inducers and inhibitors. Okay, of course, you need to describe the process involved in renal elimination of drugs and how the kidney handles drugs by filtration, by secretion, and by reabsorption. So it is the algebraic summation of these three processes that's going to affect the drug excretion through the kidneys. The role of the biliary system is very important, and the fact that there is again active secretion of drugs in bile. This is a simple fact that you need to know. No deep understanding here. All about ion trapping, as I have explained, and comparing the first order and zero order kinetics. This is again important, and again, if I tell you compare, this means that you will know everything about first order and everything about zero order kinetics, so I can ask you about each one separately. Defining the T-half, again, anything with a definition is very important, and it might come as a short answer question. And clinical applications of the T-half, of course, a constant T-half comes under first order kinetics, which means that a constant percentage of drug is eliminated or is absorbed or is metabolized or excreted per unit time. So it's a constant percentage. So if you give me one dose of a drug, after one T-half, my body will contain 50% of that dose. After two T-halves, my body will contain 50% of the 50%, which is 25% of that dose. After three T-halves, my body will contain 12.5% of the original dose. By the fourth T-half, my body will contain only around 6%, and by 5 T-halves, my body will contain only around 3%. So we say that by the lapse of 4 or 5 T-halves, the dose that you have given me, the dose that's being eliminated by under first order kinetics, is going to finish, is going to disappear after 4 or 5 T-halves. So what if you are giving me this dose regularly? If you're going to give me this dose regularly, after 4 or 5 T-halves, the very first dose is going to disappear completely from my plasma. But then you were giving me repeated doses. So the more you give, the more is eliminated or excreted. So we reach something called a steady state. So what's the significance of the T-half? Okay, you reach the steady state after 4 or 5 T-halves, and the drug is completely eliminated after 4 or 5 T-halves. So it's basically the same phenomenon. And why do you reach steady state after 4 or 5 T-halves? Because this is the time when the very first dose has been completely eliminated, and your body now is working on eliminating whatever regular doses that are administered. If you stop regular administration, the drug is going to disappear after 4 or 5 T-halves, given that this drug is following first order kinetics. To determine the maintenance dose in case of infusion and in cases of repeated regular dosing, you don't need to memorize the equations. You need just to know which factors are important. Like which factors? Like if I'm calculating the maintenance dose, I know that the maintenance dose depends on the steady state concentration and depends on the clearance. So these are two important factors that govern the maintenance dose. If I am giving the maintenance dose by infusion talks per unit time, like I'm infusing a certain concentration per minute or per hour, so I don't need to multiply by a time interval. However, if I'm giving this drug by repeated dosing, I need to multiply whatever I get from multiplying the steady state concentration times the clearance. I need to multiply it by my dosing interval, because this is not a constant infusion. This is a dose that is given at regular intervals. Okay, so we shift now to dynamics. possible mechanisms of drug action. Just as I said about the sites of drug metabolism, with drug metabolism, we are mainly concerned about the liver, but we needed you to know that metabolism can happen in many other places. Exactly the same here. Regarding the mechanism of action of drugs, it is mainly through receptors. So we're mainly interested in receptors, specific receptors of drugs. But before going into this, we also need you to know that drugs might have several other mechanisms of action. So this is something that you need simply to mention, to enumerate. It will be the subject of MCQ questions, not short answer questions. However, defining certain types of drug receptor interactions like affinity, efficacy, and potency, you need to memorize this. You need to be able to define it, and you need to be able to describe it. To determine the type of drug receptor relation for a dose response or a concentration response curve. If you see a response curve, a drug concentration response curve or a drug dose response curve, you need to be able to recognize the parallel shift, what the parallel shift means, the non-parallel shift, the decrease in efficacy. Of course, you know with a competitive antagonism that you get a parallel rightward shift of the dose response or the concentration response curve. You know that. However, if this antagonism is not competitive, okay, this means that the antagonist is reducing the available number of receptors. So this is going to impact on a drug's efficacy. You are going to get a decrease in efficacy or a decrease in the Emax of the drug. However, with competitive antagonism, you don't get a decrease in efficacy or a decrease in the Emax. So you need to explain the differences between various types of receptor, ligands, agonists, antagonists, and you need to compare different types of drug antagonism. Again, if you need to explain the differences, if you can compare, you should be able to describe each one of these separately. To describe different types of receptors and signal transduction mechanisms, you need to know by heart, because no one will explain to you this in details except the medical pharmacology department. The different types of receptors: G protein coupled receptors, tyrosine kinase or enzyme linked receptors, steroid thyroid receptors, the nuclear receptors or intracellular receptors, and the ligand gated ion channels. You should be able to describe everything here, even the subcellular mechanisms. And why is that? Because as science and medicine advances, we have more and more details about these. So in the world around you, there are more details. So this is the very basic that you should know at your level. Okay, to define adverse drug reactions, again, definitions are very important. To classify adverse drug reactions, what basically comes here is either we are going to ask you in multiple choice questions about certain characters of different types of adverse drug reactions, and whether we describe a certain character and tell you which type of adverse drug reaction is this, or we describe an actual reaction and tell you again which type is this. So you need to understand very well, for example, the difference between hypersensitivity and supersensitivity. You need to understand the differences between type 1 reactions, okay, or type A reactions that are expected, that are dose related, and those reactions that are not, or adverse effects that are not dose related, that result from allergy, that result from idiosyncrasy. You need to understand about the importance of pharmacogenomics and pharmacogenetics, although not for your year, perhaps for those who are going to be with us next year, we are going to elaborate more about pharmacogenetics and pharmacogenomics, but you already know good information about this. You know that individuals differ in their genetic makeup. just like we differ in the color of our skin, in the color of our eyes, we differ in the amount of enzymes, in the amount of carriers, we differ in the types of or the amount of receptors, we differ in the ways that we react to drugs and the way that we metabolize and excrete drugs. If these variations are quantifiable within a population, we call this pharmacogenomics or pharmacogenetics, if it's going to affect drug metabolism or drug response. So in certain individuals, some drugs might be more effective or less effective or more toxic. You need to be able to understand this, just this phenomenon. Even if my explanation seems a bit more complicated than what you have in your text, don't worry about this. I'm trying just to explain things in a different way. However, your questions are going to come exactly as written in your text. Okay, if you understand what's written in your text exactly, then you are going to be able to answer all questions without difficulty. So to define the different types of adverse drug reactions, again, you should be able to know the differences between different types. To determine the type of an adverse drug reaction by knowing its clinical description and its circumstances. This is nothing extra. Yani, for example, if you know what idiosyncrasy is, and we describe to you that a certain reaction comes from a genetic abnormality, okay, then you know this is idiosyncrasy. If you know what hypersensitivity is, and we tell you that there is something that looks like allergy, it has not been reported on the first exposure, however, it's been reported on the second exposure, and it takes the form of allergy, then you know this is hypersensitivity. So it's not going to be something difficult. To mention important precautions with different types of adverse drug reactions, again, like for example, you don't give, you have to ask the patient about previous drug allergies, and you don't give the patient a drug to which allergy has been reported before. This is a precaution. For example, you don't give drugs in overdose, so you don't get an overdose toxicity. Like for example, in patients taking enzyme inhibitors, for example, they will experience supersensitivity from certain drugs. This time not hypersensitivity. We call it supersensitivity because you give them the normal dose and you get an exaggerated response. So by knowing, for example, the effects of hepatic macrosomal enzyme inducers and inhibitors, you can expect, if the patient is taking hepatic macrosomal enzyme inhibitor, that they might be super sensitive to certain drugs. You give them a normal dose and you get an exaggerated response. Okay, so you mentioned the different dosing definitions in relation to therapy and toxicity. You have definition of dosing. You need to memorize these definitions. To describe the importance of genetics, I've already explained about this. Okay, now we come to the last slide that's talking about your practical exam. Your practical exam is going to be actually very easy. You need to know about the classification of the routes of drug administration, the advantages and disadvantages of each route of administration. You need to know the dosage forms. What's the difference between a route and a dosage form? A route is the way you give the drug. Like if you give the drug by injection, this is a route. However, when you give the drug by injection, this drug might be in the form of, it comes to you in the form of a vial or an ampoule. This is a dosage form. This is how the drug is supplied. When you give a drug by inhalation, for example, this drug might come in different forms. Just stick to what you have in your material, and it's not going to be difficult. You just need to know the classification the advantages and disadvantages, and the difference between a route and a dosage form. And with this, I end this orientation, and I hope it is clear, and I hope it helps you through your exam, and thank you very much.